Hello, everybody. Good afternoon and welcome. My name is Greg Mackling. I'm host of 680 CJOB's morning show. It's called The Start. And it says here that I'm a longtime friend of the St. Boniface Hospital Foundation. Of course, that's true. It's my absolute pleasure to serve as your host today for this inaugural Health Report 2.0 event. I was, of course, the co-host of the Health Report on CJOB Radio for almost a decade. It was my absolute honor to do that work on Sunday mornings with a variety of co-hosts over the years. And it has always been my pleasure to be associated with St. Boniface Hospital Foundation. Anyone who purchased tickets in the recently concluded St. Boniface Hospital Foundation Mega Million Choices Lottery, thank you for purchasing your tickets. I suspect some of you bought tickets so that the TV commercials would stop sooner than later. Your strategy worked. We sold out the lottery in record time, 5 weeks earlier than we had anticipated having any chance of selling out the lottery. So once again, thank you for your support and good luck in the major draws. I always like to tell people that my relationship with St. Boniface Hospital and the foundation really started July 30th, 2006. That was the day my twin boys were born at St. Boniface Hospital. And I don't know if I'd ever been in the hospital more than a couple of times up until that day. In fact, my wife and I ended up in the kitchen, in the basement, while we were trying to find the triage and the proper unit. We'd not done any sort of tour, virtual or otherwise. And from the moment that we made contact with one of the staff in the kitchen, we felt very well taken care of. My boys ended up spending nearly a month in the neonatal intensive care unit. I'd never heard of the NICU until I was standing right in the middle of it, speaking to Sue McMahon, who ran the unit, who has since become a friend of mine. She was telling me what the next month was going to be like. So my relationship, as I said, began in that first month of my twin boys' lives. They are now going to be 15, coming up in July. They started out life less than 5 pounds combined. They're now almost 12 feet tall combined. They're big boys. And so I'm forever grateful for the care they received at the NICU at St. Boniface Hospital. And so if I can give back a tiny bit by being associated with events such as these and the lottery, I'm certainly happy to do that. In the coming months, I'll be chatting with leaders in patient care and research at St. Boniface Hospital. As some of you may know, St. Boniface Hospital is marking its 150th anniversary. Sesquicentennial is the terminology attached to that. That's a word that I would probably not normally use in my everyday vocabulary, but that's what we're celebrating, 150 years of excellence at St. Boniface Hospital. Across Canada, we are winding up Heart Month. February makes sense, right? Right in the middle of February, we have Valentine's Day. So Heart Month is a regular celebration across the country here in Canada. And of course, you may not know this, or you may know that St. Boniface Hospital has a long history of excellence in cardiac care. In fact, Manitoba's very first open heart surgery was performed in 1959 at St. B by Dr. Morley Cohen. The procedure was a resounding success. It was performed on a boy who was just 5 years old at the time. An incredible story that if you go and you dig things up on the internet, if you're fond of doing such things, it's an incredible story. From that historic moment, St. Boniface Hospital took its place as the leader in cardiac health. And today it is Manitoba's Cardiac Center of Excellence. Now that brings us to today's event. I couldn't be more pleased to introduce our guest, Dr. John Ducas. Dr. Ducas is a cardiologist at St. Boniface Hospital. He's also an associate professor of medicine at the University of Manitoba. A little bit of history on Dr. Ducas. After completing a medical degree and training in internal medicine and cardiology at McGill University in Montreal. Dr. Ducas moved to Winnipeg in 1982 for research and a fellowship in cardiology at the University of Manitoba. At the U of M, he was the head of cardiology from 1988 till 2002 and the director of the catheterization laboratories, I hope I said that right, from 1998 through 2005, and then again from 2014 until 2018. He is currently the medical director of the Manitoba Acute Coronary Syndrome Network. Dr. Ducas has previously served on national committees for the Canadian Cardiovascular Society, the Heart and Stroke Foundation of Canada, and provincial committees for the Manitoba Medical Association. Currently, Dr. Ducas is the chairperson for Health Canada's Scientific Advisory Committee on Medical Devices used in the cardiovascular system. He is also the president of the Bethune-Bai-Kuen Canadian Alliance and Medical Humanitarian Group that has traveled to China over 10 times, I wanted to say 100 there, since 2008, visiting impoverished rural areas, providing medical consultation, donations, and teaching. Dr. Ducas's research interests include acute coronary syndromes, coronary atherosclerosis, and interventional cardiology. He has participated in many clinical research trials and is the author or co-author of more than 90 papers in peer-reviewed journals and 7 book chapters. Dr. Ducas regularly holds cardiology clinics at First Nation communities across Manitoba and in Nunavut. I'm thrilled to have this opportunity for us to chat with Dr. Ducas about an initiative he is truly passionate about, the importance of calling 911 at the first signs of heart attack. Now, before we get things rolling, I'll share a couple of housekeeping items here, since this is an unusual format for some of us. Dr. Ducas and I will talk for about a half an hour. Following the interview, I'll turn the proverbial microphone over to you, and we'll have about 15 minutes or so for you to ask questions. So jot them down if something comes across your mind. Don't forget it, write it down, and then we can have you ask a question here. So without further ado, please join me in welcoming Dr. John Ducas. Hello, Dr. Ducas.
Well, Greg, thanks for the introduction.
It's outstanding to be with you again. Now, just so people are wondering at home, what are you guys doing about social distancing? Dr. Ducas and I are in the same building, but we're in separate studios so that we're obeying all the public health orders and keeping one another safe. So I thought it'd be important that you know that we're doing all the right things today. St. Boniface Hospital, of course, known as Manitoba's Cardiac Center of Excellence. Very proud of that, very proud to tell folks about that. About how many heart attacks does the hospital treat each year?
Well, major heart attacks, we treat about 700. Anybody in the province that has a heart attack will be sent to St. Boniface Hospital, if not right away, within the first 24, 48 hours. There are smaller heart attacks, of which is over a couple of thousand, that we also manage and treat. And again, they all will have a trip to St. Boniface. So every day, 2 major heart attacks and about 4, 5, 6 of smaller heart attacks, come our way.
Those numbers, when you break them down by day, the number of events like cardiac events or heart attack per day, that I think draws a real important picture, Dr. Ducas. For those of us that don't know, and hopefully most of us will never know, but what are the signs of heart attack that people should learn to recognize either in themselves or those around them, those that they love, those that they live with, those that they work with?
Yes, Greg. Well, the most common thing is discomfort or pain in the chest, arms, throat, or neck. That's the most common thing. One thing I teach the medical students is don't always use the word pain. Sometimes patients will say it's not a pain, it's just a discomfort. So that's by far the most common. About 90% of people will have that. Then over and above that, while you're feeling this, sometimes it's so severe, you're nauseated, you vomit, you can sweat, that might happen also. There can be shortness of breath, there can be dizziness, there can be fainting, and some people, they just don't feel right. Something's wrong. Now, the typical symptoms are more in the younger people. The atypical symptoms are more in the older people. Somebody that's 90 years old, 80 years old can just doesn't feel right. One thing also that I'm sure many people have heard is that women might feel a little bit different when they have a heart attack. And yes, that is true. There's a couple of reasons for that. One of the reasons, though, has to do with age. Women will have their first heart attack usually about 10 years older than men. And so if you kind of age match the symptoms of a heart attack for older men and women of the same age, often it's about the same. The other unusual thing is that women will suffer two kind of different heart attacks that men don't usually get. And we can talk about that if you like, but so that's
Yeah, why
another.
don't we, I think that's important because I was going to ask you about that. It wasn't on our list of questions, but a lot of us know that those differences do exist.
Yeah, women, the first thing that's really unusual in some women is they can have what we call stress-induced cardiomyopathy. It was first discovered in Japan, and the Japanese called it Takotsubo's disease. And Takotsubo is a type of octopus net that they use. And one of the pictures on the x-rays that you take of the heart reminded them of that. So what is this? This is due to stress. And the stress can be, I just saw a car accident, my husband died, or it could actually be, I won the lottery. That can be a stress too. And they will have chest pain and have everything just like a regular heart attack. It's usually postmenopausal women, so they will often have the same symptoms. They will dial 911 if they're smart, and they'll be brought, and we will see certain different types of patterns on our treatments, and we will treat them in a slightly different way. The other interesting difference with, and with the stress-induced cardiomyopathy, it's about 80–90% women. Very unusual to see it in a man. The other type of unusual heart attack that women have more than men is they can have what's called spontaneous coronary artery dissection, which we abbreviate as SCAD. And this is due to a little rip that will occur in the lining of the heart arteries. And when that rip occurs, it can block the artery, and it can again cause chest pain, nausea, vomiting, feeling unwell, trouble breathing, the usual type of symptoms. When they have this, again, if they're smart, they'll call 911 and they'll be coming into the hospital right away. You can die from both the stress-induced cardiomyopathy and from SCAD, so it's important to be treated. The treatments, though, are different, and as I said, they're more common in women.
Well, I mean, we've even gone as far as to name types of heart attacks based on gender, right? The Widowmaker, there's zero acknowledgement of women in that name. And so our thinking has really had to change over the years, hasn't it, Dr. Ducas?
Yeah, the Widowmaker, again, is due to a narrowing in one of the heart arteries right at the beginning of a heart artery, the main one that goes on the front part of the heart. And the reason it's called the Widowmaker is that it can make widows.
Well, there you go. So based on your experience, and this is really why we're here today, now with that extraordinary background and what to look for and some of the different types of cardiac events or heart attack that we can suffer, based on your experience and record keeping, this being your passion, about how many heart attack patients in Winnipeg, Manitoba actually do dial 911 when they should?
Yeah, that's a good question. When we first started record keeping on this, about 15 years ago or so, it was about only 30%. So the vast majority of people would get in their car and come to an emergency room. It kind of crept up to about 40-ish%. And then in the last couple of years, I think because of COVID and also because of the closing of some of the emergency rooms, which means that, it's not as easy to go to an emergency room. It crept up to sort of 50%. I'm real worried though. I'm really worried that when COVID goes away and as time goes on and people get more familiar with urgent care centers, they might opt once again to mostly come on their own to the emergency room, which is a big mistake.
We're meeting on technology here today. How big of a problem does WebMD and other websites like that pose for us? Can they be a hindrance in terms of people doing the right thing in your mind?
Well, minutes count. And if you're having a heart attack and you're going out and logging onto your computer and trying to search on Google for WebMD or whatever other, website you want, uh, precious time is going on. And two things are potentially putting you at risk in that precious time. We have a saying, time is muscle. Once a heart attack occurs, it occurs because there's a blockage of a main artery, the Widowmaker artery, for example. That blockage occurs because of a blood clot that forms on some cholesterol buildup. And as the time goes on, muscle downstream from that blocked artery, from that blood clot, starts to die. The sooner we can unblock that artery, the less heart muscle will be damaged. So that's the first jeopardy that you have. The longer you take going online, trying to figure out what's wrong with you, the more muscle potentially is going to die until you can get the life-saving heart muscle sparing treatment that we can give. The second thing that can happen is the heart's rhythm can go out of kilter. The heart can start beating too fast or too slowly. And that's really scary, because when that happens, you can lose consciousness. And if that happens to the point that your heart doesn't beat anymore, you will die. So think about this. You're having some chest discomfort. You're at home. You say, I don't know what this is. I can't believe this is a heart attack. I'm going to get into my car, or I'm going to get my wife to drive me or my husband to drive me. And while you're driving, your heart decides to stop at that point because of this blocked artery. And if you're not on a heart monitor, like an ambulance will provide to you, you will die. You will die. So it's a sad and tragic thing. And sometimes there's not actually a lot of heart damage that triggers this arrhythmia, the stopping of the heartbeat. There's one patient that I'll never forget. And he started having a heart attack at home. He got into his car, and on the trip to St. Boniface Hospital, he crashed into one of the ambulance stations, lucky for him, and was resuscitated by the crew and brought the rest of the way in, and we saved his life.
Wow.
There's another patient that haunts me that had followed for many years. He was a little overweight. He had some other problems, diabetes. And I kept telling him, you've got to take care of yourself. You're at risk for a heart attack. And sure enough, one day at his house, he collapsed because his heart stopped. His wife started CPR, called 911. They eventually brought him to St. Boniface Hospital, but it was too late by then, because not only is your heart dying, your brain is dying if you're not getting oxygen for enough time. So it was just such a sad thing to know this individual for so many years. A few months before he died, before he collapsed at home, he was in London, England, and he sent me a postcard. And a few months later, I'm hugging his wife, trying to console her that he died. How often does that happen in a heart attack? About 1 out of 20 people, their heart will stop in the first hour. So you don't want to be driving to the hospital if that could happen to you. You don't want to be a statistic like that. So dial 911. Your heart damage can be stopped quickly. Time is muscle. And if your heart does go out of rhythm and stops, the ambulance attendants can almost always get it started again.
Well, let's pick up on that, because obviously, if you're behind the wheel, that's one thing to put yourself at jeopardy. You could also put the drivers and motorists and pedestrians around you in jeopardy as well if you make that fateful decision. But also with regard to the notion, I think some people might have the impression, Dr. Ducas, oh, well, I can get to the hospital faster. Is that true?
Well, I don't know. I mean, think about that. If you dial 911 in the city, the statistics are it's about 7-8 minutes before first responders will show up. So you're not often going to get to the hospital faster than that. And if you do, are you going to park the car and you're going to get out? And even if you do that, you have to walk from the car into the emergency room. They're going to start to register you. You're not on a monitor then. There's more than one patient that I have treated that while they were standing, getting all the information, their Medicare number, they collapsed in the waiting room of the emergency room. If they would have called 911, they would have been on a monitor for 15, 20 minutes by that time. But the most important thing is that we have a system set up here that the ambulance attendants will do the cardiogram at the scene, at the house, at Polo Park, wherever. And they will transmit that to a doctor on call. And the doctor on call will look at that ECG. And if it looks like it's a heart attack, will direct the ambulance attendants to bring the patient directly to the heart cath lab, which is where we unblock the vessels, the blocked arteries. So that means no having to go to the emergency room, no having to get registered. When we've done statistics on this, the average time from first medical contact to having an open artery in the heart cath lab is 68 minutes if you dial 911 and 120 minutes if you go to an emergency room. So it's almost half the time, because the emergency rooms, especially urgent care centers, are not really geared for that. And then they will have to call an ambulance to bring you to St. Boniface if you're not already in St. Boniface. Even the patients that come to St. Boniface Hospital, the average time to get up to the heart cath lab to unblock the artery was about half an hour longer than the ones that dialed 911 and went straight to the cath lab.
Well, and if I live in an area, I live in North Kildonan, and maybe my instinct is to go to the urgent care at Concordia Hospital. Well, now I've gone to the wrong place. If the paramedics come to my house, they know what's going on with me. I'm guessing. And if I'm guessing wrong, that means I'm driving myself to the wrong place. Time is muscle, as you mentioned, and I'm doing myself a whole world of hurt, not to mention the risks involved there. So some incredibly sound advice and statistics to back it up, and some things for us to think about. Dr. Ducas, you joined us on the start on Tuesday morning on CJOB. And one of the common comments from our listeners was, well, ambulances are too expensive. That's why I would not call an ambulance. That's why I would drive myself there. We also had one woman who called to texted in to say that her aunt lived 5 minutes from St. Boniface Hospital, and about 8 years ago tried to drive herself. She did not make it in that short drive. And so she wanted to really emphasize the message that it's more prudent to call 911. What do you say about the cost?
Yeah, well, I've got bad news for everybody out there. Our healthcare system is not perfect. There are strengths and weaknesses that it has. Not everything is covered. Dental work is not covered. Some eye work is not covered. Some physio is not covered. And medications aren't covered. And one of the things that is not covered is ambulance fees. However, I have to hand it to our government. Since they've took over, they've cut it in half. It used to be $500. Now it's down to $250. And I don't think anybody's going to end up in debtor's prison if they don't pay this. I'm not recommending to ignore the bill, but my goodness, you could save your life. And imagine the cost to your family, to your loved ones if you die. And actually, it's maybe worse not to die, because you could be incapacitated after a big heart attack. And that's going to cost you a lot more if you can't work and you can't earn a living and you can't interact with people. So these are things that people have to understand. One plug I want to make, though, I don't want to forget.
Yes,
It's not only within the perimeter highway. We have the same system with the ambulance service in the near rural areas. So if you live in Selkirk or Steinbach or Portage La Prairie or Boundary Trails area, we have it set up so that the ambulance attendants will do the ECG on the scene, contact the doctor on call, and bring the patient directly to St. Boniface Hospital without going to a local emergency room. We also have treated people that are a little farther away, people in the Nipawa area or beyond. And the ambulance brought the patients to the local emergency room at the same time that STARS took off with a helicopter to go pick up the patient. So there are options all over our province to get people treated as quickly as possible, save their lives, and reduce damage to their heart.
I think during this pandemic, a lot of us have gotten used to a variety of different ways to do things that we would have never normally done them the way we do them now. And the thing that comes to my mind is curbside pickup, and the notion that I can wait for my food at the restaurant, or for them to put my package together at my favorite store while I'm at home. And then I go there and I call them, and then boom, they bring me to my car. I don't have to do all the things that I would normally do when I have to go shopping. And I think that there's a similar benefit in terms of the time continuum process and equation there, right? The fact that if I call 911 and when those paramedics show up, they're going to start treating me immediately, versus if I drive myself or have myself driven to hospital, my care doesn't begin until I get past that triage nurse.
Yeah. And actually, if you're not sure, you're at home, you don't know whether this is a heart attack or not, you dial 911, the person on the other end of the line will know the questions to ask. Will try to sort out whether this could be a heart attack or not. So if you're not sure about it, absolutely dial 911 and they will give you the advice you need. Maybe it's not a heart attack. So find out, make the call.
There's professionals on the other end of that phone. It's a great point, Dr. Ducas. So let's talk about a happy ending, or we've done the right thing and we've been treated. Maybe we've had stents installed or whatever type of surgery has been required. Talk about the medical treatment options for heart attack, and how do you decide which to use?
Well, that's real important. I started doing this job, I think 150 years ago or so, when the St. Boniface started. That's how long I feel like I've been in practice. But back then in the 80s, when I shook the hand of a heart attack survivor back then, I was shaking the hand of somebody that had an over 80% chance of eventually dying of heart disease. Most of these patients would die of heart problems. Today, after a heart attack, if you survive and I'm shaking your hand, assuming you were treated properly, it's more likely you're going to die of something else than heart disease. You're more likely to die of some other problem. And the reason for that is medication. We have had a huge amount of progress and ability to control the very things that cause the process. The process is caused by cholesterol buildup in the heart arteries, and we have excellent drugs to treat and lower cholesterol that are safe and effective, and now are all off patent mostly and quite cheap. There are some expensive ones, but most of the ones we use are inexpensive. Another problem that occurs is because of blood clotting. We have excellent drugs that will prevent blood clotting safely in patients that are at risk of having future heart attacks. We now have great treatments to control blood pressure. Blood pressure was a big pain in the neck a few years ago, but now it's really easy to treat most patients with high blood pressure. And of course, diabetes. We have a real good handle nowadays on controlling diabetes, which is another bad risk factor for heart disease. And we have other things that didn't exist when I started. Great rehab facilities, refit and wellness in our city, which can nurture people along, get them to exercise. And if they participate in programs like refit or wellness, cardiac rehab programs, they have a much lower chance of having another heart attack than if they don't. And finally, we've gotten smarter and smarter about cigarette smoking and about exercise. I can remember nurses smoking on rounds and doctors smoking on rounds. I can remember that. And nowadays the numbers have fallen so much, which is a great thing. It's just a great thing. I don't remember my father jogging, but I go jogging, and that's something that's important. So exercise is another important aspect. So now, there's great hope if you survive, if the damage is minimal, that you're going to have a normal, healthy life, and there's something else that's going to knock you off, not another heart attack.
The question period is going to start shortly here. So if you've got some questions for Dr. Ducas, type them in to the chat option on your browser or on your computer. You can click in there and type away. We will see your question. We'd love to ask your questions. This doesn't have to be just Dr. Ducas and I speaking. Hopefully we're answering most of your questions in advance, but please feel free to join the discussion. And Dr. Ducas, you mentioned that survivability and the rate of survivability that's changed. It's almost switched, right? It's gone from that 15% survivability to now it's 85%. It's quite extraordinary, isn't it?
Yeah, we've done so much progress here. Our rich Western countries, Europe and North America, heart disease is no longer the #1 killer. On the other hand, if you look at the planet Earth, cardiovascular disease is the #1 killer. And that's because in the middle income countries, people have become richer. They still smoke. They don't take care of themselves as well. They don't have the use of medications. And so we have made huge progress here. When I go to other countries, I can see that they have bigger problems with heart disease than we do.
So in terms of future complications, what could we be dealing with if a heart attack is not treated quickly enough and we've traded that time for muscle, not intentionally perhaps, but that's what's happened? What are we running the risk of?
Well, the first problem you get is the heart's a pump. That's what it does. It pumps the blood. And if you damage the heart, it won't pump as well. And the body responds to that lack of pump function. The body says, there's something wrong here. I'm going to start saving fluid, and fluid buildup will occur. And what does that cause to people when they have a damaged heart from a heart attack that had happened in the past? Well, they start accumulating fluid. They start accumulating fluid in their legs. Their legs become swollen. They start accumulating fluid in their lungs, and they have trouble breathing and can't walk around or exercise normally. They can't even lay flat in bed, if they have too much fluid on board. They can also just be generally weak. There's not enough oxygen going to all the muscles and the rest of the body, and they can feel wiped out 24/7. In some of our worst patients that had a lot of heart attack damage, they are stuck in hospital literally for months waiting for a heart transplant. Some of them end up having a special heart pump that we can put in. It's like in a small case. They can be discharged with this while they're waiting for a heart transplant. So these are some of the things that I've seen with my own eyes that have happened to people that were just delayed and couldn't get treated, fast enough, or didn't get treated fast enough.
Yeah, you don't want to be dependent on that technology. It's wonderful knowing that it exists, but I don't think you want it necessarily to be a part of your long-term strategy. One of our viewers that's joined us today would like to know, what is congestive heart failure?
Okay, well, I just led into that. If the heart pump function has been damaged and the heart's not pumping adequately, the body's response to that is to start saving fluid so that you have fluid buildup in your legs and in your lungs. And the medical term for that is congestion. It's just like traffic congestion. Well, you have fluid congestion building up in your legs and into your lungs, and it's not a pleasant thing, and you have to take strong medications to clear that fluid out.
One of our viewers would like to know, with the current pandemic situation, is calling an ambulance even more important than it's otherwise been? Less important? Where do you fall on that?
It's the same important. It's not any more or less important. We've noticed less people coming to emergency rooms and less ECGs done. If you look at all the ECGs that we do within the city of Winnipeg, it's actually fallen since the pandemic has occurred, which means to me that people are not coming to hospital and seeking care at the same rate that they used to. But it doesn't matter. I mean, if you're having a heart attack, well, you can die. If you're having a heart attack, you should dial 911. It's as simple as that.
Somebody else wants to know, this is a good one, I like this one. If one of my loved ones seems to be experiencing a heart attack and they are resisting calling 911. What should I do?
Let me tell you a story. Once a year, we hold an annual educational event, which we call Heart Attack Day. And a few years ago, we have speakers that speak to healthcare professionals about it. And one of the speakers that we had was an emergency room doctor. And he stood up and sheepishly told us the story of his heart attack. So we're talking about a healthcare professional, a doctor that knows what a heart attack is. He drove himself to the hospital. Now, you know, the human mind is a very complicated machine. And the way you interpret things is affected by so many things. It's affected by denial and feeling of invincibility, various fears, knot-headedness, if you speak to my wife. There's just so many different things that factor into decision making. And some people, they will not be convinced, you know, to dial 911. Someone once said that heart attack should be like broken hips. You know, once it happens to you, you can't really walk yourself to the car and you have to call an ambulance. Things would be a lot simpler if you had no choice. But this is a free country and people have a free choice to make good decisions or bad decisions. So my plea to everybody that's listening is, if you're not sure, dial 911. Let them give you the advice instead of your wife or your husband or whoever else that you may not think knows what they're talking about. Let them try to convince you that the best chance you have is to make that phone call.
Yeah, I think it's terrific advice. So much good advice here today. One of our viewers asking, is acute onset of jaw pain indicative of heart attack for women?
Yes, it could be. It's one of the potential signs of a heart attack. You know, again, when I teach the medical students this, I try to tell them that you have to think broad about this. Most people, chest pain, but some people, jaw pain, arm pain, some people, no pain at all. There are people that have, in quotations, silent heart attacks, and they don't even know it. And 2 or 3 days later, they're in this congestive heart failure with fluid buildup. And it wasn't their fault. They just didn't know it. They did not perceive pain. You know, when we evolved a few million years ago, there was nothing in it for evolution to get people to understand, you know, heart pain. If an animal was chewing on your right ankle, you needed to know about that so you could do something about that animal chewing on your right ankle. But if you were having some heart problem or kidney problem or something, there wasn't any reason to have the nerves hooked up in a particular and a precise way. And so that's the problem with what we call visceral pain. The heart is a viscera, it's an organ. And organ pain is sometimes very unusual. Why would you feel heart pain, which is in the center of your body, in your jaw? Well, that's just because the nerves that are hooked up to your heart interact with other nerves that are hooked up in your spinal cord, and you may perceive this in your left arm or in your jaw because it's a visceral pain and it's not meant to be precise.
I think so many of us treat some of our health issues, Dr. Ducas, like we do issues with our car or with our home. You know, I know I'm not an expert on a lot of stuff, but I used to change the oil on my cars. I don't even do that anymore. So I think maybe part of the message here is that as much as we think we know, the quicker we realize we don't know very much about this, the better off we're going to be.
Yeah, you know, look, dial 911. The person on the other end will tell you what to do.
We also have someone asking, is there increased heart attack for women with diagnosed atrial fibrillation? Is feeling occasional lightheadedness a symptom of incorrect type or dose of medication? I'm getting a bunch of questions like this, and I just want to send this out to those typing out your questions. It's not appropriate really for us, Dr. Ducas. I don't think, maybe I'll let you comment on this, to be doing any sort of medical assessments here today. That's quite impossible.
Yeah, you know, for me to give advice to, which I'm happy to do. I love giving advice, but atrial fibrillation is an apple and orange type of thing. It's not a heart attack. It's due to an irregular heart rhythm, and it can be life-threatening also, and it has to be properly treated. And so if you have atrial fibrillation, you need to speak to your doctor to make sure you're on the right treatments for that. But most people with atrial fibrillation will not have a heart attack. It's a different process.
So would our advice be today for those asking very specific questions? I would say the best advice for us to give you today is to get in touch with your doctor and go and see your doc.
Yeah, that's what we're here for. And nowadays in pandemic world, it's easier to see patients because you don't see them, you call them up. And yesterday, it's starting at 8 o'clock and ending at 4 o'clock. I spent the whole day on the phone talking to my patients. You know, I had a whole clinic done at home. So it's easier nowadays to get a hold of your doctor.
That's amazing. So many people who look back to the good old days wishing that doctors did house calls. Boy, you don't get much closer than that, right?
I can remember in the, I guess in the late 50s, when I was sick at home, my mother would call the pediatrician who would be driven in his chauffeured car up to our house, and he would get out and do the house call. Well, how many people have chauffeurs these days, and how many doctors do house calls these days?
One other question here. Does it happen often where you have a patient that is actually having a stroke, but they think they are having a heart attack and could be treated incorrectly?
To have a stroke means the process is actually very similar. It's a buildup of, it's usually caused by a buildup of cholesterol in a blood clot forming, but instead of in the heart artery, it's in a brain artery. Now, the one little thing that's different about strokes is some strokes, maybe about 1 out of 5 strokes, it's due to bleeding in the brain. So that's a little different. But the key thing about strokes is it's damaging the brain, and the brain functions will then stop working right. So you will have trouble talking, you will feel weak, you feel numb. It's usually on one side of your body or the other side. So it's a little bit different. You know, and again, if you're not sure, dial 911. There is a process to treat patients with strokes right away also. And so if you're not sure, you can just dial 911 and they'll help you with it.
If you're just joining us, we've got a question here about the difference in signs of heart attack between men and women. We can recap that before we shut things down. We did go through that a little bit earlier, but we don't mind doing that again. Is taking daily aspirin still recommended? What about when you think you're having a heart attack or stroke?
Okay. Taking daily aspirin is a great question, and there's been so much research in the last 50 years about that. There's been large randomized trials where half the patients got the aspirin and half the patients got a sugar pill, a placebo. And what the message is quite clear these days. If you've had previous heart attack, if you've had previous strokes, absolutely there's a benefit to take a daily baby aspirin, an 81 milligram aspirin. If you've never had a heart attack or never had a stroke, there is no proven benefit. And the reason is aspirin is a two-edged sword. Yes, it can stop blood clotting, but it can also cause bleeding. And people that have never had a heart attack or never had a stroke, they have very tiny chance of a future heart attack, actually, as long as they're not having other problems like high blood pressure and smoking, et cetera. And so the chance of them bleeding is actually higher than the protection they may get from the aspirin. On the other hand, if you've had a previous heart attack, well, these are people that are at risk of having future heart attacks. And although they can also bleed at the same rate, they get actually more protection, and the balance is in the favor of taking the aspirin. Now, the other part of the question was, what about if you think you're having a heart attack? If you think you're having a heart attack, call 911. But what the first thing they're going to tell you, if they agree with you that you're having a heart attack, is to take an aspirin. Now, what kind of aspirin? Well, if it's a plain aspirin, take the whole plain aspirin. You're better off to chew it and swallow it. If it's a coated aspirin, a baby aspirin, again, especially if it's coated, you want to chew it up in your mouth so it can break it up. The coated aspirin takes longer to melt. There's actually research that shows that aspirin will save lives. So yes, take an aspirin, but have the 911 people recommend it.
Got some really great questions here, and I just want to acknowledge them one more time here. Some of them are really kind of going into some specifics here, into the weeds, so to speak, that don't necessarily have a broad ability the questions are very specific, and so maybe not, this is not necessarily the forum for them. But one of our attendees here had a heart attack in 2011, had open heart surgery in 2012 with microflow implant in the aorta. 2019, I think plaquing is the word that they're trying to type here, without aneurysm. Should this be checked regularly? And this attendee would like to know about TAVI procedures as they were checking them out with him back, or her, it was her, back in 2012. Is that something that's become commonplace?
Okay, well, there's a lot to unpack there. First of all, if you've had previous bypass surgery, previous valve surgery, previous surgery on your aorta, you need to be followed by a specialist. This is something that I would not recommend a GP following, and that's it. And there are enough cardiologists now in our province that you should not have any problem at all getting to see a cardiologist once or twice a year. If you've had problems with your aorta, you should be followed by a vascular surgeon. And again, there are enough practitioners out there that can manage you. It's impossible for me to give the right advice unless I see the patient and know all the details about the history. But rest assured that our province will provide these services for you. And the other great little part of that question was about TAVI, which has got nothing to do with heart attacks, but still it's a great question. And when people have bad heart valves in the aortic position, that's one of the heart valves, in many instances, we now have the technology to fix the heart valve without opening up the chest. Now you have to admit, you have to fulfill certain very strict criteria for it, but that's a technology that's growing. And again, that goes back to what I said before. When I started this job, it was entirely different. We didn't even understand what the cause of a heart attack was. As crazy as that sounds, we did not understand the actual cause of a heart attack. And now we know it right down to the last letter. When I started this job, the thought of putting a heart valve from your leg artery up into your heart, no one even dreamt about this. And this is something that we're doing now. So these are the amazing things that I was so fortunate to see in my career over these years. It's just amazing the progress that we made.
Well, my mom suffered with something called hypertrophic cardiomyopathy, and she had to have surgery in her early 40s that essentially saved her life and gave her probably an extra 7 or 8 years of life. So very grateful for the advances in cardiology and cardiac medicine over the years. Could you have ever imagined, Dr. Ducas, that there would be a time when you would prescribe something called prehabilitation for people who are waiting to have heart surgery, encouraging them to be active and to go out and get exercise while they're waiting to have surgery on their heart?
Absolutely. And, for the people that are listening today, the donors that are listening, other people that support St. Boniface Hospital, it's so important to know the value of your contributions and your support. None of this would be possible without the support of people that have given money over the years to the Heart and Stroke, to St. Boniface, so that this research can be done to figure out what the best treatments are. And we are so fortunate for those people. And there's somebody else we have to give a shout out to, all of the patients that have participated in randomized trials. We do a lot of randomized trials, clinical research at St. Boniface. And when we go to approach a patient to see if they'd be willing to take a placebo or to take an active drug, a lot of people say, yes, sign me up. I want to do something to help fight this disease that snagged me. I want to do something that I can contribute to. So the people that support the foundation, the people that support Heart and Stroke, and the patients that offer their bodies, to see what the best treatment is. These are all important people that have to be acknowledged so that you can understand why we have things like TAVI and treatments for heart attack, et cetera.
A really good point, Dr. Ducas. There's more than one way to give back. It doesn't necessarily have to be through a donation or buying lottery tickets. It might be through your time and showing your appreciation that way by getting involved in some of these incredible research projects that go on here in Manitoba, because we are not only is St. B the Center of Cardiac Excellence in terms of care, heart research is a big deal and something Manitoba does very well, and not too many places that do it better than at St. B.
Absolutely. We're very proud of that. We have a strong group of researchers that work within cardiology and also cardiac surgery at St. Boniface Hospital. We punch above our weight.
Yeah, talk about that really quick here. We're slowly running out of time here, but just that ability for a cardiologist to do not only to care for patients on one side of the parking lot, but then to maybe to take the tunnel into the Asper Research Center or Albrechtsen Research Center and do research, and to see the value and the payoff, so to speak, of that research and that inspiration to serve their patients better. That connection isn't done everywhere.
No, it's an important connection. People that are not in the doctor business, they don't, sort of understand that to be an academic physician, to work for a university, you have to be focused on three things. Number one, take care of your patients. Number two, participate in research. And number three, teach. These are important three pillars of all the university doctors that we have. And we try as much as possible to do good in all of these three areas.
Well, Dr. Ducas, so many great topics we've covered off. Some of them were on the list and several were not. So thank you for being so flexible with your answers. I do want to just quickly though, because we did have the question a second time, even though we covered it off, just quickly, that difference, if we could. Men and women, for so many years, we thought their hearts were exactly the same, and the research were done on male mice. And now we realize that there was a faux pas made along the way. And we're redoing a lot of that research. And we know that women experience heart attack differently than men.
Well, I wouldn't make the blanket statement, all women are different than men. That's not 100% correct. The correct way to put it is that women may have different types of problems, symptoms, presentations, and causes of heart attack than men. A run-of-the-mill average heart attack in a man and a run-of-the-mill average heart attack in the women are the same. Women are a little bit older, that's number one. And so just as men get older, descriptions are a little bit different and complaints are a little bit different. The second thing is that women have two different unique causes of heart attack that are unusual in men. And I mentioned them before. One of them is stress-induced cardiomyopathy, also called Takotsubo cardiomyopathy. And the second thing is they have spontaneous coronary artery dissection, also called SCAD. The key thing that everybody should remember, whether you're a man or a woman, is if you're not sure, if you're having some weird sensation and you think maybe it's a heart attack, dial 911. The person on the other end of the phone will help you walk through this thing and get you the right treatment and care you need. And that way you don't have to be a doctor and you don't have to try to think back on all the differences women might have and men might have, because they know that's on their algorithms, that's on the questions they have to ask.
I like that a lot. I just wanted to pass this along from one of our attendees. Marlene says, I am a graduate of the St. Boniface School of Nursing. I currently live in Ontario, where I volunteer as a spokesperson for the Heart and Stroke Foundation for my region. Dr. Ducas, thank you for enlightening us all. We appreciate your talk. I appreciate it so much. So maybe that's a place to end. We want to thank you for spending time with us on the other side of your computer, on your computer screen. Dr. Ducas, thank you for this. And this whole notion that 911 matters, time is muscle, some tremendous messages here. And I think the one thing that we can all do is maybe just share this knowledge with somebody that we know after this seminar today.
Thanks a lot.
So before we close today's event, I want to let you know that we've recorded today's event. This seminar is going to be available for you to consume later if you missed it, or if you decided that you got something out of this and you'd like to share it with someone that you care about, someone that you love. Visit the foundation on social media at, and this is for Instagram and for Twitter, at STBHF, St. Boniface Hospital Foundation. We'll provide that info in the chat and share with your circles if you can. We'd love for you to do that. You could save someone's life, and that's really why we're here today, is to get that information out. This incredible research Dr. Ducas has done, this wealth of knowledge that he has over these years in cardiology. We're sharing that with you. And also be sure to watch for details on our next Health Report 2.0 event, which will be coming up later on this year in the spring. Thank you to everyone for joining us today. Once again, Dr. Ducas, thank you for sharing your expertise. Thank you to our friends at Bounce for producing today's event. And we'll bid you adieu. Hope you have a wonderful afternoon. Thanks for spending some time with us today.